Hello, my name is Bob Groom. I am so grateful to Sherry and Mohammed for this opportunity to be part of this conference this year. I've been invited to speak about developing a perfusion program in Africa. And this is a topic that I am particularly passionate about. So I'm very excited to share with you. I hope to give you some insights about what cardiac surgery is like in Africa, and maybe inspire you to get involved and to be part of helping develop cardiac surgery in Africa. It's very fitting that I should be attending your conference in Indiana, because the place where I serve is Tenwek Hospital in eastern Kenya, in Bomet, Kenya. And that hospital was begun in 1937 when an organization called World Gospel Mission sent a nurse to Bomet, Kenya to open a clinic. So how fitting that today I should be speaking with you about Tenwek Hospital, something that has grown and expanded to a great area of patient care for a great region of Kenya. And it all began right there in Marion, Indiana, just northeast of you. Today, Tenwek Hospital is a referral center for southwestern Kenya. We have about 15 million patients or people in our catchment area. We're a 380-bed teaching hospital with a wide range of surgical, medical, and maternity and orthopedic and pediatric care. We receive about 200,000 outpatients every year for care, 25,000 admissions, and we do about 10,000 surgeries in 7 operating rooms. And on the map here, you can see where we're located in the eastern part of Africa, the western part of Kenya, right near the equator. Disclosures: I'm a global worker for WGM. It's a faith-based organization that has hospitals all over the world. I also have to share that I'm responsible for raising all of my expenses to serve at Tenwek. So if you contact me, I might well ask you to talk to God about how you might help me in this work. My outline for today is to speak about the need for cardiac surgery on the continent of Africa. And, I'm going to share a lot of statistics and data with you, but what it boils down to, the need is for individual patients, and I think sometimes focusing on individual people that suffer with heart disease is a good way to keep this alive and keep this real to us. I was planning on sharing strategies to serve, but given our limited time, I'm going to skip over that topic and encourage you to contact me directly if you want to know more, hear more about some of my strategies about serving on a mission hospital anywhere in the world. And I would just say to you that it's important to have a strategy that includes the head and the heart. Be thoughtful about how you plan to serve, and that's very important to understand what can be done and what is possible, and have an understanding about that, and also to have a passion to serve with your heart, with the desire to help others. You need a good balance of those two things in order to be effective. Sometimes when we serve with just the heart, we get off track and we overpromise and underdeliver. But when we use both our head and our heart to serve, we're able to establish a good relationship or a good understanding. And we just heard how important those relationships were from Tammy on her lecture just prior to this one. And the third area I'm going to talk about is perfusion at Tenwek from 2009 to 2023. So just to put it in some context, Africa is a massive continent. It's larger than you think, 11 million square miles in all. And if you could take that continent and you could put China, the US, India, Japan, Eastern Europe, Western Europe, all on top of that continent, you would still have room to spare. So it is a massive continent, and it's just hard to get your head around how big it is. In terms of population, in 2020, the census showed there are about 1.3 billion people live in Africa, about 53 million in Kenya, where I serve. One of the things I like about the place where I serve in Bomet, Kenya, is that we're right on the equator. And every day the sun rises at 6:30 in the morning and it sets around 6:30 in the evening. So we don't have daylight savings time and we don't have those dark evening drives home from work, but the sun comes up at the same time every day. The region where I serve is very diverse in terms of the nature that is there. Many beautiful animals and many beautiful foliage, and the savanna of the Masai Mara is a beautiful place that I frequent often. There's also quite a diversity of people there from many different tribes in the area where I serve. Kikuyu, Maasai, Ma, many tribes and many different people with many different cultural heritage, and it's a rich area with wonderful foods and people. But beneath the veneer of all this beauty and natural resources, there's a problem, and I hope to pull back that veneer for you for a few minutes and share with you some of the challenges that people in sub-Saharan Africa face. This article in the New York Times in September of 2018 described rheumatic valvular disease, rheumatic fever, as where a sore throat becomes a death sentence. And this is the highest rate of rheumatic heart disease is in sub-Saharan Africa, where I serve. And it all starts with a bacterial infection where a group A streptococcus gets embedded in the pharyngeal epithelium, and it activates macrophages and T cells, and these cells get processed and they get confused and they begin to attack tissues in the body, the heart, the brain, the joints, and the skin. In the case of heart valves, those T cells and macrophages attack the valve tissue and cause elongation of the cords and calcification and destruction of the valves, as shown in this cartoon here. With a normal heart, here you see the calcified thickened valve, and this is one of the largest populations of patients we see are patients with rheumatic heart disease. This map shows the prevalence of rheumatic heart disease, the death rate per 100,000 across the world. And here you see the red and the green are the highest rates, and sub-Saharan Africa happens to be the area that is afflicted by the highest rates of death from rheumatic heart disease. Verwoerd and colleagues attempted to get their arms around access to cardiac surgery around the world in this publication that was in 2020. And what they found was about 2/3 of the world's population, about 4.5 billion people, do not have access to cardiac surgery. They looked specifically at the distributions of heart surgeons around the world. And here you could see where greater than 10 per million in the US and Canada and Europe and Australia, but areas like sub-Saharan Africa, the number of surgeons is quite lower. And here's the same type of display of pediatric heart surgeons, distributions of surgeons. And again, you can see in sub-Saharan Africa, there are very few surgeons. Looking at it a different way from that data, in North America, there are 11 heart surgeons per million population and about 2 heart surgeons per million population, two pediatric surgeons. But in sub-Saharan Africa, the rate is 0.04 per million for adult surgeons and 0.03 pediatric surgeons. So you see a 300-fold difference in the number of heart surgeons and subsequently heart programs in the area. But the problem's even bigger than that. There's a problem of primary care and accessibility to primary care in Africa. And this diagram shows the number of doctors per person in various parts of the world. And for example, in the US, we have one doctor for every 390 in population. But in Kenya, where I serve, there's one doctor for 7,400 patients. So you can just imagine how challenging it is to see a doctor, and consequently, patients that come to us with cardiac disease are well advanced in their disease. They're in stage 2 and 3 heart failure, and sometimes stage 4 heart failure when they first reach the hospital. So it's a perfect storm with sub-Saharan Africa as the epicenter, with a shortage of surgeons, a shortage of primary care providers, and a lot of heart disease. The story of Abigail is an example of what some patients face in finding heart surgery in Africa. Abigail and her father, David, they learned that she had rheumatic heart disease. She had aortic and mitral valvular disease. And to get care, she came to our facility. They traveled 3,500 miles to get the care that they needed. This is Abigail 3 days after surgery. She really wasn't smiling, but I did prompt her to smile. And she had a great recovery and returned to her home in Liberia. So the humble beginnings of our program at Tenwek would date back to about 2006, where we did this evaluation where 120 patients who had suspected rheumatic heart disease from previous hospital visits received echo exams. And what we found in those 120 patients was that about 20% had a normal echo, but 45% had a rheumatic heart disease, 29% had some congenital cardiac lesion, and then there was a small number that had TB or cor-pulmonale or cardiomyopathy. At that time, there was no heart surgery at Tenwek Hospital, but at least we had an idea of the magnitude of the problem. Since 2011, we've had visiting surgeons and visiting teams come to Tenwek that have trained and have stood alongside our team and helped us to develop this team. These are some of the surgeons that came. James Fingleton from Brown was the first surgeon that came. They did several, this was in 2008 actually, and I think they did several closed mitral commissurotomies. John Gallant, a surgeon from Florida, Brian Bolton, Michael Smith from Cincinnati, and Lyle Joyce have all come here to teach and to help grow this program. In addition to the individual surgeons, we've had a number of teams that have come. These are mostly pediatric cardiac teams that have come to Tenwek, and they come every 12 to 16 months, and will come for a period of 1 to 2 weeks, and we'll do congenital heart surgery when these teams are there. Here you see the growth in independent cardiac surgery at Tenwek Hospital dating back to 2011, when about 20 cases were done by the local team that year. But over time, we saw some growth where more cases were done. And interestingly, during the COVID period from 2020 to 2021, we had a growth in the cases that were done by Kenyan teams independently. We now do about 250 cases a year at Tenwek Hospital. As I mentioned before, most of it is rheumatic heart disease, and These are the prostheses we use. We do some prosthetic valves. The majority of the patients receive a mechanical valve, in that these are adolescent patients, and a tissue valve would simply calcify within 4 or 5 years if you placed a tissue valve in a patient like that. And some annular rings for tricuspid disease and mitral valve disease. So between 2008 and 2012, we operate about 817 patients. The congenital cases were from 3 months to 33 years old, with a mean age of 2.5 years. The age of the rheumatic patients was 7 to 73 years, but most of the patients were young. Most of the patients were in the range of 13 to 17 years old. Very young patients presenting with aortic and mitral disease. Most of the patients presented in New York Heart Association class 2 and 3, and many of them had moderate systolic dysfunction with ejection fractions ranging from 30 to 45. So that's a little bit about the type of cases we do. In 2021, my perfusion team at Tenwek Hospital, we conducted a survey of Kenyan cardiac centers to find out about the training and practices of perfusionists in Kenya. There are 13 perfusionists in the country that practice at 10 centers across the country. 7 of the centers are in Nairobi, in the capital city. Then we have one in the central western part of Kenya at Eldoret. Tenwek Hospital, where I serve, is also in the west, and then one center along the coast in Mombasa. So the 13 perfusionists at that center told us about their background, their practice, and what they believed about standards and guidelines. And so some of the things we learned was that the median clinical experience was 5 years. So the 13 practicing perfusionists, many of them are very young in their training, with a range of 1 to 22 years of training. The median annual number of cases done by a perfusionist in Kenya is about 54 cases per year. While I mentioned there were 10 programs, some of those programs only do 20 cases in a year. Tenwek Hospital, where I serve, we're the largest program from a volume standpoint in Kenya. We asked about background. We asked about how people were trained, and we found that 2/3 of the perfusionists, they started out in anesthesia as a nurse anesthetist or as a clinical officer in anesthesia. We asked about the duration of their training. We learned that 1/3 of them they didn't receive formal training, but they trained on the job. And then we learned that about 1/4 of the perfusionists, those that practice perfusionists in Kenya, had less than 1 year of training. So with this information in mind and understanding the need for more perfusionists in Kenya, we developed a certificate program at Tenwek Hospital. Initial program was a 1-year training period with 80 hours of lecture, and with students would be proctored on 80 cases and then complete exams to receive this intramural certificate. We are currently in the process of developing a program that's recognized by the Clinical Officers Council in Kenya, that would be a program endorsed by them as a level of higher education for nursing. The 3 pillars of our perfusion education program are didactic lectures. There's about 120 hours of lecture, and it's based on the recommended units from the ACPE, the same curriculum that is used recommended for perfusion schools in the U.S. An important part of our program is high fidelity simulation. I enjoyed the session earlier about the Califia the virtual simulator. We have a Califia simulator here, and it's an important part of our training program. And we put our students through 40 to 60 hours of simulation before we let them be involved in caring for a patient. And then they'll have 90 cases where they undergo evaluation before they graduate, and pass an oral and written exam before they graduate. These are the units in our curriculum, the same units that are used and recommended by the ACPE and KHAP. We've added one unit, spiritual formation. We believe it's very important that that staff understand their mission, and their work is the abilities they have are a gift from God, and they are to use those abilities to bring healing and comfort to patients that suffer. The lectures many of the lectures are delivered by invited faculty, and here you see some of our invited faculty. Luke Puis has talked about standards and guidelines. George Justison has given a series of lectures on the goal-directed perfusion. Joe Sestino, pediatric perfusion. Al Stammers has talked about coagulation management. So we have a number of invited faculty that help us deliver this curriculum, and it's a wonderful thing to have our students learning from some of the thought leaders and educators in the field. And you see there's a spot here, your photo here. So this is an invitation for you to contact me if you have if you're a skilled teacher, if you have a gift of teaching. We should talk about how you might fit in helping us at this program. This is the leadership of our program. The program's nested in the College of Tenwek Hospital College of Health Sciences. The principal of the school is Jackson Masonic. Russ White, the chief cardiac surgeon, is the medical director. I'm the program director, and Mr. Philip Koesch, one of our first trainees, is assistant program director of the school. Our training plan is to educate 22 perfusionists in 5 years. We get many calls from countries all over Africa asking us to train staff. Can we send somebody? Can we send a CRNA? Can we send a critical care nurse to come to your center and learn about perfusion? So currently our plan is to train these 22, 12 for internal students and 10 external students that could work in different countries. As I mentioned, simulation training is an important part of our program, and we are so blessed to have a Califia simulator, and we can take students through some extreme situations in the sim lab, and before they're ever in the operating room. Here are 2 current students who began the program in January. This is Daph Rose. Daph Rose is from Rwanda, and we're very excited to have her as a student. Tenwek Hospital also has a cardiothoracic surgery fellowship, and so we currently have a fellowship from her hospital, King Faisal Hospital in Rwanda. And so the 2 of them are getting educated at our program, and we're very excited about the opportunity to train 2 people that can go back to that center and really help it to excel. You've all have seen the simulator, and Richard did a nice job of showing us the control screens today, but you have an instructor and a student, and it's wonderful. And we have this mounted in our sim lab on an S3 pump. We used S3 pumps in the OR, so students learn on this pump before they ever do a case in the operating room, and we put them through some really interesting paces. We allow them to go on bypass without turning the oxygen on. we make really bad things happen, and as soon as they get comfortable, we'll change the patient's rhythm. So it's a great learning tool, and particularly for countries in a continent like Africa, where there are a limited number of cases, the ability to train through simulation is very valuable. It's very valuable, and it really helps us to excel the education experience. As I mentioned before, we have a fellowship program with the College of COSEXA, the College of Surgeons in East Central and Southern Africa. And we train fellows to become heart surgeons. Currently, we have this massive expansion going on. We're building a 198 beds hospital with 6 procedure rooms, including a hybrid room, a cardiac cath lab. We'll have the capacity to do about 2,000 cases a year at this center. It will have all the modern conveniences of an OR with pendants and camera systems and lights and laminar flow. So just winding up here, it's said in the Sanhedrin, if you save one life, you save the entire world, including yourself. And I think you can appreciate the daunting task of providing care in countries in the continent of Africa, sub-Saharan Africa. And these individual patients, we're able to care for some, a small number, but we believe that's so valuable, and we believe we have the opportunity to train and develop programs there. This is Travis. We met him, my wife and I met him in a Maasai village when he was 6 months old. He weighed 6 kilos. And in March, he was able to receive surgery at Tenwek Hospital, closure of a perimembranous VSD. And so we're delighted to see individual patients receive care. I know this was short. I invite you to contact me. My email address, robert.groom@wgm.org. I would be glad to go in more detail and share more with you about our work at Tenwek Hospital, and just share with you my experiences from serving on mission trips over the last 12 years. Thank you very much.